This episode of EMS One-Stop is brought to you by Lexipol, the experts in policy, training, wellness support and grants assistance for first responders and government leaders. To learn more, visit lexipol.com. That's lexipol.com.
It really is leaving our paramedics available for the next big call.
Guilford County EMS is rolling out a new team to take some of the stress off paramedics and give patients more individualized attention.
It's called IMPACT, which is short for Interagency Medical Provider Assessment and Care Team. Fox 8's Madison Forsey got an inside look at how the team works.
The calls that we're running, like the fall calls, the checkups, the things like that, it's more face-to-face interaction.
That's what Chelsea Dye loves about her EMT job.
Let's say we go on a fall call, and you get there and you have a grandmother, right? So you don't know if she's been alone or if she's lonely. Maybe she just wants a conversation with somebody.
She could take those extra few minutes to check in with patients through IMPACT. Guilford County EMS leaders looked at 275,000 911 calls over the past 3 years and found a pattern.
Eye injuries, dental pains, falls, medical alarms, welfare checks, things where the patient may need some sort of assistance, but is not necessarily going to need a transport to the hospital.
IMPACT will handle those medical calls without taking someone to the hospital. They started thinking about the team during the pandemic when staffing was down 30%.
Before we started this program, if you had fallen and you weren't injured or couldn't get up, it would be anywhere from a few minutes to 20 or 30 minutes, just depending on how busy our ambulances were.
In September, they started training, helping EMTs get more knowledge on assessing a patient's condition.
And then this is going to be your oxygen tank.
The truck is stocked with everything an EMT needs to respond.
If you do have a need that changes, or we get out there and determine that you need a higher level of care, we're going to get you that ambulance or that paramedic immediately.
IMPACT works with the patient to help them get the right medical help once they make sure they're okay. The team is also partnering with the fire department to run these calls. During their trial run, they were able to take 8 to 10% of the daily call volume.
If we're running that fall call or running that checkup, it may give them time to be able to sit and eat or have a little bit longer to just kind of relax and get everything back together so that they can go back out and run.
Hello and welcome back to another edition of EMS One-Stop. I'm your host, Rob Lawrence, and the clip you just saw there was from a TV station out of North Carolina, Guilford County to be exact, talking about the Interagency Medical Provider Assessment and Care Team. And it's a really cool and innovative community project that's going on there. Now, if we just left that clip and ended the podcast here, that is in itself would be a great explainer. But I want to go a bit further today and bring in my guests who are the power behind the program. And that's Hannah Muthersbaugh and Justin Harget from Guilford County. Welcome to EMS One-Stop.
Thanks for having us.
So let's start off with just some introductions. I didn't want to read your bios out because I think you have such amazing backstories. I want you to tell it for yourselves. So Hannah, who are you? What do you do? And what's your role within Guilford County?
Yeah, thanks again for having us. So I'm Hannah Muthersbaugh. I'm the Assistant Medical Director for Guilford County EMS. I'm also an emergency medicine PA and have been for the last 10 years. So I actually started my medical journey as an EMT, initially with a rescue squad at UNC Chapel Hill, the South Orange Rescue Squad. Is where I got my EMT and then came to Guilford County with a full-time job. Quickly got my paramedic and did that for a number of years. And I just loved emergency medicine. So when I went back to PA school, I actually initially promised my husband that I would get a regular job, that I would work in a clinic and we would have a normal life. And I think he always knew that was going to be a lie. So immediately into the emergency department I went, and within the first year was back at Guilford County as an assistant medical director, and have continued to do that. And it really is my passion. It's what I love most about medicine. So.
It's clearly a family job. We should give some props to your husband, Scott, because, of course, he is the organizational PIO as well.
He is. So he runs our social media. He handles our any of our media inquiries. He handles lots and lots of things that really help us navigate the wild, wild west of social media, and I really appreciate it.
And actually, I have to say, perhaps I'm contractually obliged to say he's doing an amazing job, and we'll continue to follow Guilford County. Anyway, Justin, please introduce yourself.
Hey, so I'm Justin Harget. I'm the operations manager for Guilford County Emergency Services. I have about 17 years in the emergency services community. I started out as a volunteer firefighter, spent some time as a career firefighter, hazmat technician, and then I kind of went to the dark side of EMS and really enjoyed it. And so I started out kind of part-time, got my feet underneath me, and then quickly moved to paramedic. And like Hannah said, it's just really my passion. Emergency medicine has been great, and I've been able to move up into leadership and really try to help impact our system and be innovative in the things that we do so that we can make it better for our people every day. And that's really the goal.
So talk about Guilford itself. Where is it located? The size of the system, how it's organized, just really to kind of give us some sort of, establishing information before we talk about the program.
Sure. Guilford County is right in the middle of North Carolina. We call it the Piedmont Triad area. Guilford County has about 550,000 residents. We could see up to 1 million in population during the work week. It just depends on the week. We have a very large urban, rural, suburban type interface system where we have, some areas that are 30, 45 minutes away from our hospitals. And so we have a good mix of those call types. Last year, we ran about 90 to 93,000 calls. And then we also have a convalescent service that runs about 10,000 convalescents in our system as well that we don't have to handle because they're there. That's about 254 calls a day, 56% transport rate. And we do that with a mix of static staffing and then PDU staffing as well, that peak demand unit model.
So it's fair to say, like the rest of the country, of course, you have had your challenges with, recruiting and all those things we saw, which, of course, a lot of people are now pointing the finger at the pandemic over. But, of course, that in itself led you to try and think of solutions to not only help the organization, but obviously help the community. And I think, this perhaps was the nugget that created impact.
Yeah, absolutely. So Guilford County put their first ambulance on the road in 1969. But by 1980, we were a full ALS service, meaning we sent a paramedic to every single 911 call. And so we did that for a long time, but as volumes grew, it just wasn't sustainable. So in 2017, we piloted a BLS project where we put a BLS transport unit on the road. And they had their own protocols, a set of subdeterminates that we sent them to. And it worked really well. They almost immediately became our highest utilized unit in the system. But then, like you said, by 2020, we were at a 30% staffing deficit. And we had to do something different. And so we just really started thinking about what we could do different. We sent some surveys to the field to try to help understand what some of the pinch points were. We surveyed our supervisors, our telecommunicators, and the feedback we got was brutally honest. It was really hard to read, but it highlighted for us a set of system stresses that we were like tangentially aware of, but weren't sure about all of the details. And so it really helped us think about how we could try to fix some of those things. And that's ultimately how we came up with this idea of trying to send a non-transport unit. So we, at the same time, we're also in the NAEMSP quality and safety course. And so they really helped us think through this idea and this project. They helped us come up with an aim statement to make sure that we had a reachable goal. And the goal was to remove 10 calls every 12 hours out of the system. And so that is my shameless plug for the class. If you're involved and you want to take it, it's totally worth your time. But I think more than anything, they were not only an incredible support, but they really helped us learn how to look at the data, manipulate the data, and use that to help us understand where we were and where we needed to go.
So I'm glad you mentioned NAMSP, because I guess this podcast and video is almost part of my kind of concluding report from NAMSP. We've just had the National Association. And by the way, I'm trying to get rid of acronyms because we just talk in acronyms in EMS, there we go, in emergency medical services all the time. And so we've just come back from the National Association of EMS Physicians. I have to say, and hopefully you guys will agree with me, it was an outstanding conference. Also, really, congratulations to our good friend Mike Taigman, who got the Keith Neely Award for his contribution to EMS and particularly to quality. So let me just take a second to say congratulations, Mike. Well deserved. I saw, and we spoke down there, and I really sort of latched on to this program and thought, well, this is something that everybody needs to hear about because of the way that already you've described the fact that you've had those issues, you went and asked the people, the staff, what they wanted. And I think all staff surveys can be brutal. So congratulations on, not only doing that, but also listening to what's being said and then doing something about it. I think that's vitally important. And perhaps, another takeaway for all. But so you decided you need to do something different. You went to the EMS safety course. And by the way, we'll put the link in the show notes for that because it's a great course. And I think I have actually interviewed the good folk from the EMS safety course in a previous edition, and I'll find that and put that in the show notes as well. So you went through the data, and of course, as everybody knows that listens to EMS One-Stop, data is my favorite four-letter word. So let me just get that out there. So you went through the MPDS codes, you went through the data, you went through the contacts and calls you've had. Why?
We wanted to make sure that whatever we did was safe. And we had to start with somewhere. We had to look at what we had done in the past because that's going to help us to learn, where we're going in the future. And fortunately for us, we're a very, very large system that has a lot of call volume and a lot of call data. And so we were able to really get a good data set out there. We looked at about 275,000 calls in our data set, and we were looking at calls with high refusal rates. So more than 60% historically, not ones that we had told people to go refuse. We've never done that. We won't do that. But these were already high refusal rates. And so we were able to narrow our codes down to about 39 initially, where we felt it was really safe for us to do that. We can send a link out in the show notes, I'm sure, with the codes that we used, but we included some safety criteria. And so those safety criteria were cardiac arrest rates. So we wanted a really low cardiac arrest rate. So less than 1.5% is what we picked. A low emergency transport rate, that told us that once our folks were there, they felt comfortable transporting this patient. There was not any real emergent needs. And so that was less than 3.5%. And of course, we wanted to look and make sure we had enough data in that subdeterminant. And so it had to have at least 100 events. What we found was that we actually had some Charlie and Delta calls that we could include into this non-transport BLS, but as a system, we didn't feel like that was safe to do. We didn't quite have that comfort level, but there certainly were several codes out there that we could have sent a BLS unit to and met our safety criteria.
Right. And I think that's the point we start to emphasize the fact that we are talking here about sending BLS, EMTs, to these calls that, of course, then saves the medic for the higher acuity stuff. And I think that's absolutely, a point that we have to emphasize and re-emphasize as we go through this. Now, based on the fact that we've done our MPDS analysis, we've identified there is a cohort of patients that don't need, and hopefully non-red lights and sirens, another current paper this week published, responses. They need something, but it's not necessarily a paramedic unit. And so you then, I guess, had to select the people to do the job. Hannah, how did you do that? And what training did they go through?
Yeah, so much like Justin said, we're really concerned about safety. And so that meant sending these people to the right calls, but it also meant making sure they had all the right education to make a good decision. And so EMTs that ride our BLS units have to work in our system at least 6 months, and then they have an additional week of what we call senior EMT training to kind of help them with their decision making. So we took a cohort of volunteers from that group and said, let's give you some additional training. So we talked about this program, we talked about why, we talked about what it was going to look like. We talked about our values for this program, and much like Justin mentioned, we specifically told them the goal is not to encourage a refusal. It is not to encourage not going to the hospital. We will never refuse a transport. If they want to go and they want an ambulance, they can have one. But is there an option to get them the right care some other avenue? Do they need a transport? Do they need an ER? And so once we kind of talked about the values of the program, we gave them some additional clinical training. And that was a didactic presentation and case studies from me. And then I actually took them and put them in the emergency department with me. I specifically scheduled them for the shifts that I was overnight as the provider in triage, because what I wanted them to get out of this was assessment skills. And so we would process about 30 patients a shift. I had a big spreadsheet for them to fill out as we did the assessment. They were allowed to ask questions. And then after each patient, we went back, looked at their spreadsheet, and kind of talked about the patient presentation, what some of the concerning red flags were, and whether or not the patient needed an emergency department. And so I think that gave them a lot more confidence, and it certainly gave me a lot more confidence that their decision-making skills were where we wanted them to be.
Excellent. Before we go any further, let's just take a second and have a message from our sponsor.
Lexipol empowers first responders and public servants to best meet the needs of their residents safely and responsibly. Serving more than 2 million public safety and government professionals in over 8,000 agencies and municipalities, Lexipol offers a range of solutions that includes policies, training, behavioral health resources, news and analysis, and grant assistance services for law enforcement, fire and rescue, EMS, local government, and other agencies dedicated to public safety. To learn more, visit lexipol.com. That's LEXIPOL.com.
The county is using an innovative approach called IMPACT. The new Interagency Medical Provider Assessment and Care Team pairs a smaller, more nimble response unit to calls that likely won't require transport to a hospital.
This impact team, which by the way is the first of its kind in the state, can help not just put the right resources there, but put them there quicker. I often say we need to match task with talent when we're talking about people. We need to do the same thing with resources, matching resources with the need. Instead of having a $300,000 unit responding, they may have a $75,000 unit respond that can provide the resources that are needed at that particular time.
Welcome back to EMS One-Stop. You had the amazing voice of Jim Dudley with the Lexipol ad read there, and also another visual from Guilford County's program, which I think, again, is pretty much self-explanatory. Don't forget, if you're listening or watching, you can listen to us on wherever you get your podcast from. And also the video version of this is available on YouTube, on the EMS One YouTube channel. So if you're listening to us now and you want to see what we are showing you, and of course the advantage of doing a vodcast is that we can put lots of visuals, lots of videos up for you to view, or indeed if you're just sitting on the truck, which probably statistically half of you are, then of course you can listen to us on Apple Podcasts and anywhere else you get your platform. But most importantly, don't forget to like and subscribe. If you're looking at us on an iPhone right now, there's a little plus sign at the top. If you press that, it means you've subscribed. And it also means you get notified every time an episode drops. Same on YouTube. Just hit that like button and then it will click up on your phone when a new episode arrives. So please make sure you do that. And also, please, please, please give us a 5-star rating. We love a 5-star rating. We're talking about the Interagency Medical Provider Assessment and Care Team from Guilford County with my guests, Hannah Muthersbaugh and Justin Harget. And sort of moving on, let's just talk about, so we've established the data, we've identified the people, we've done the training, but I guess we have to tell other people about the program. We have to get the partners together. And of course, we have to tell the citizenry. So Justin, I mean, how did that happen?
So we were able to engage our stakeholders through, from going to fire chiefs meetings. Our PIO engaged the media. We were able to put out public service announcements that we were going to be changing these kind of responses, but it didn't mean they were going to get any less care. It actually meant that they were going to get care faster. Our system is so busy and so dynamic that by us using an alternate unit, we were able to actually get them care faster than they traditionally would have. By not sending an ambulance and sending a first response vehicle with trained medical personnel on it. I think the other thing that we had to do was we had to go get the buy-in of our other public safety partners. We're a third service agency here. And so we had to rely on our fire partners to really help us to supplement our system as we grew bigger. Our staffing deficits they're improving, but we're still in a place where we need to add more staff as our call volume grows. And so we were able to engage our fire partners, and they have been a really big success point for us. They have taken on codes on their own that they traditionally would have never run, and they're running them without EMS units very successfully. And so they were able to pull out about 6.6% of our call volume over the past year or so, and that is an incredible statistic for them to go out on 4 EMD complaints and be able to pull those off. Additionally,
let me jump in there then. So when somebody uses a statistic, I always say percentage of what? So what's the number? What is that?
So out of the 90, Out of the 96,000 calls in our study system here, or study here, they were able to pull out about 6,300 with no EMS response at all that we would have otherwise sent an ambulance to, and likely with a paramedic on it.
That's remarkable, and it's the way to go. Sorry, I didn't mean to butt in, but of course people need to listen, need to understand just the sheer scale of the numbers that you're talking about here. Sorry, do carry on.
We also partnered with our police department with a behavioral health response team where we put EMS personnel in a police squad that specializes in behavioral health. And they're able to pull out calls that we were getting for police checkups, for mental health clearances. And so just in their first year or so, they were able to pull out about 500 calls that we never sent an ambulance to that we were sending as well. So that's been a great kind of piece to our mobile integrated healthcare here in Guilford County.
That's fantastic. And you mentioned the PIO, and we've already talked about him, but clearly public engagement, public information, and just get him to understand, because, you know, we talk about the Johnny and Roy model for many years, and I think it's kind of almost, you know, ingrained in the legend that is, you know, US EMS. But, you know, the paramedic arrives on scene, you go to hospital, and of course you're breaking that mold. And so it does require a lot of information and a lot of understanding, and of course great ways to explain what you're about to do. And so I think we can't underestimate that, you know, public information effort. I've had the same discussion with the folks that are doing the red lights and sirens stuff, that we've got the evidence that says we should do it, but actually the public need to understand why we've stopped putting on the lights and sirens, for example. So a great explainer and a great public information campaign is absolutely critical, I think, in doing this. And that's cool. So you have great partners, you have the folk in place, you've identified the results. You're a year or so into this now, so you know you've got the evidence to continue for it to go through. But you know, what have been the challenges though?
Yeah, there's no project without challenges, right? And so a couple of the ones that we faced was upscaling our EMT training. So it was really easy to put those 9 EMTs in the emergency department with me. Several of the other things we did early on with this test group was that we initially rode with them. They would go in and make contact, and we would be in the truck with our ALS gear in case something went awry. And then we were, after that, available always by phone or radio. So upscaling that to close to 100 EMTs and a 24-hour model got a lot harder to kind of have that hands-on guidance. We've continued to think about case studies, high fidelity simulation, and ways that we can continue to give them that clinical training. Staffing and equipment has always been a challenge. And so of the 920 potential shifts, we were able to run 303 of them with our EMS impact unit. And so we find that our fire cohorts are really, they're fully staffed, they have fixed stations, they have fixed codes, and so there's not a lot of variability there. But there's a lot more variability with our people just because of the staffing challenges and there only being one unit that's covering a large area. Process automation always helps with decreasing variability, but isn't perfect. And so, you know, our fire cohorts have a very automated dispatch system. We are also using CAD, right, an automated dispatch system, but it's recommending our unit on a regular basis, but it's not necessarily dispatching them. So it takes a telecommunicator touch, and there's some human variability there. We're hopeful our CAD upgrade next year will help fix some of those problems, but one of the things we still struggle with. And then culture change, right? This is always what we're talking about, even in terms of kind of responding red lights and sirens and the unit that you're getting. So for our people, it's always been the closest unit instead of necessarily the right resource. And so we're really trying to change that mindset. What resource does the patient need in the right time frame? And our fire cohorts have been such great partners in this. Different departments are kind of upscaling or downscaling their involvement depending on their availability. And so that does change our ability to respond with this particular unit as well. So we'll see how that goes as we move forward.
Excellent. And one of the reasons I was drawn to your project and to you guys is that 15 years ago in the UK, when I was the chief operating officer there, we had the rapid response EMT. And it was a senior EMT who had a lot of experience, a little bit of extra training, but actually they too were trusted to get out there and deliver did I say life-saving care? Because sometimes basic life support to the cardiac arrest requires initially a basic level of just getting there and doing. And so that's, for full disclosure, what drew me to you guys. Thank you for highlighting, the issues and challenges, and obviously that now moves on to the to-do list. But also, Justin, we're in the legislative season right now in terms of state houses, and certainly in terms of federal. We are about to go to EMS on the Hill with the National Association of EMTs to talk about TIP and TAD, treatment in place and transport to alternate destinations. So this is actually very much the theme of the year. But locally, of course, let's use the F word here on EMS One-Stop. How is it all funded?
So we were able to go to our commissioners and to our county managers and say, this is what we want to do. We put it in as a program enhancement request once we had the data. And our local governance was very supportive, and they gave us some initial funding to put this through and to do a proof of concept. And so they have supported this program and a couple of other of our MIH programs and continue to do so. And of course, we want to grow and expand it. And so it's going to be very important for us to continue to gather the data, to continue to show success, and to go back to the table and say, hey, this is what we're doing for our community. This is why it's making a difference. And of course, they want to see their constituents and the citizens of our community taken well care of. So so far, very supportive, and we are certainly appreciative of that.
And I think the theme of all of this, and in fact, I was chatting to North Carolina's own Regina Crawford only this week, and obviously she's doing a lot of work with everybody in the state in order to up the increase in level of funding for EMS, is data. Going there with a coherent story, which is based on fact and not just because gut reaction, we've always done it this way, or indeed, as I said this to Regina a long time ago, that when somebody asks you how much money do you need and you say a lot is a word, not a number. You need to have the number ready to say this is, and the evidence behind it. And so I commend you for what you're doing. That's fantastic. Now, of course, you've already started to win awards for this, right?
That's right. We have won the National Association of Counties Award for this project. And so that's been fantastic. We were selected to come present at the National Association of EMS Physicians, which also was a great way to get our story out. And so lots of agencies are coming and asking questions, and we certainly appreciate that. And, it's been an honor to be able to be a part of this.
So let's pick up the NAC, the National Association of Counties. That is a huge deal because it's not EMS. It's those folk that are currently having to run and fund their localities, probably doing what we're doing, scratching their heads thinking, how are we going to afford to do this? And of course, coming in with some sort of local solution. I think that's a major deal, and that needs to be highlighted as well, because it's a bit like our friends out in Royal Ambulance won the Glassdoor Award for the 50 top places to work in the United States. That's a non-industry recognition of something really, really good, and you guys have done the same thing. So I commend you for that. And the National Association of Counties, for others listening, you should actually look to become involved, certainly in that, maybe local chapters or local areas, because that's huge. And those people are the people that fund pretty much the localities around the country, and so that's a big deal. Final question, always a Rob question: is there anything I've forgotten to ask, or anything else you need to tell me about the program?
So I would say that we would be remiss not to highlight our EMTs that work in our system, especially those that have been the innovators on this project, who jumped on board from day one and said, "We're all in. We're gonna do this. We want it to be successful." And we realize there's going to be challenges, but we're going to work really hard with you to make this happen. And so really this program falls on them. We did the background, we did the data collection, and we get to go present it, but they're the ones who have made this successful, and we'll continue to do so as we move forward. And so our Guilford County EMS EMTs, they're the rock stars in this. And I just really want to say thank you for all the work that they've done and continue to do.
Great, that's well said. And and I think that the last thing I had on my list to ask you, Hannah, was, of course, you talked about the challenges. There are lessons that you identified, and obviously, you are, as you move into the next year of this, hopefully with Justin getting all the funding that you need. Are there any next big things or next additions to the program that you want to do?
So our primary goal is to get it up and running 24 hours a day. That's our first goal. And then I'll actually let Justin talk about several of the other initiatives that we've got going on within our system that are really cool and not specifically impact related, but kind of in the same model of getting the right care to the right patient at the right time.
That's fantastic. Right patient, right place, right time, right level of treatment with the appropriately trained person. And you're doing all of that. Well, you certainly made an impact on me, pun intended. Hannah and Justin, thank you so much for joining us. And final question. So how can we follow the program? How can we follow the organization? How can we get in touch if we want to learn more?
Yeah, absolutely. So Scott, our PIO, has made an incredible QR code that will link you to all of our social media that we can either hopefully put in the show notes or a flash up. And it's a good way to stay in touch. And then Justin and I are always available by email.
And finally, are you going to be telling this story at any other conference coming up? Can we actually come and hear you live?
I don't know that there are any current plans at the moment, although we've had some good conversations with potentially discussing this program with First Watch. We utilize them pretty heavily, and they actually were part of our safety net of criteria when we were looking at making this program safe. So one of the triggers we use for First Watch is the 48-hour recall. And so we can take a look at any patient that calls back within 48 hours. And so it's a great product that has helped us ensure that this continues to be safe.
Excellent. That's good to know. And you know what? I think if you're out there, you're planning a conference and you want to hear about an amazing community program that's exceptionally well done, come and talk to our good friends here in Guilford County, because it's a heck of a story, and the evidence and the outcomes are there for everyone to see. And so I think this is exemplar. So for the moment, and I'm going to catch you again. Don't worry, we will meet again and carry on this conversation. But for the moment, both of you, thank you so very much for joining us.
Thanks for having us.
Thank you for having us.
So that was another edition of EMS One-Stop. What an amazing story of great people doing great things. And of course, within the theme of this year, we're focusing very much on the community paramedicine, on mobile integrated healthcare. And by the way, in my view, is MIH isn't a word, it's a list: mobile, integrated, and healthcare. And I think the Impact program certainly has achieved that. And so more to follow on that, more to follow on tech as well, as we sort of develop those two things as our themes for the year. But for the moment, this has been EMS One-Stop. I've been your host, Rob Lawrence. Don't forget to follow us, like us, subscribe on all the platforms that you're either listening or watching to us on. Until next time, bye for now.